BDS first years, welcome back to the Dental Catalyst. So today we are staging an academic rescue for your head and neck anatomy paper. We are tackling a very massive, heavily repeated exam question, usually asked for 5 to 10 marks for your exams, the superior orbital fissure. Now if you open any standard textbook, you are greeted with a very terrifying dry list of about 10 different nerves and vessels packed into a very tiny space. Most students try to rote memorize this list the night before the exam. They panic, mix up the names, and lose a guaranteed 5 to 10 marks. Now we aren't doing that today. So in the next few minutes, we are going to draw a simple geometric map right here on our digital chalkboard. By the time this video ends, you will not only remember every single structure in order, but you will also understand about superior orbital fissure syndrome so well that you could explain it to a clinician. Now grab your notebooks and let's rescue your score. First, let's understand where we are. The superior orbital fissure is a cleft that connects your middle cranial fossa with the orbit of your eye. So to draw it for the examiner, don't try to draw a realistic skull. Just draw a simple tilted teardrop or a pear shape just like this. Now, here is a secret landmark that every examiner looks for on your answer sheet. Right across the middle of this teardrop, you have a fibrous ring, which is a common tendinous ring or the annulus of Zinn. What is it called? The annulus of Zinn. Now this ring is our gatekeeper. This common tendinous ring is our gatekeeper. So it splits our fissure into 3 different sectors. So the lateral and the superior sector, the middle sector, and the inferior sector. Now let's populate these sectors from top to bottom. Up here outside the ring, we have 3 nerves and a vein, which is marked in blue. The first one is lacrimal nerve. The second one is the frontal nerve. And the third one is the trochlear nerve. L, F, T. And here you can see there is a vein too, which is the superior ophthalmic vein. We have a mnemonic here to remember these nerves, which is live free 2, which belongs to the upper lateral and superior sector, which is the first sector. Now, if we look into the middle sector, we have 4 nerves. The first one is the superior division of the ocular motor nerve. We also have the inferior division of the oculomotor nerve. The other 2 nerves in here are the nasociliary nerve and the abducens nerve. So, the superior division of the oculomotor nerve, the nasociliary nerve, abducens nerve, and the inferior division of the oculomotor nerve comprises the middle sector of the superior orbital fissure. Now, on the last or the inferior sector, we have a single vein present, which is the inferior ophthalmic vein. So now, let's just analyze the mnemonic in here. Live free to see no insults at all. So these are the structures passing through the superior orbital fissure. which is the lacrimal nerve, the frontal nerve, the trochlear nerve, which is passing through the lateral and the superior sector. We have the superior division of the oculomotor nerve. Then we have the nasociliary nerve. We also have the inferior division of the oculomotor nerve and the abductor nerve passing through the second or the middle division, middle sector. And then we have the inferior ophthalmic vein passing through the inferior sector of the superior orbital fissure. So please do remember the mnemonic in here. Live free to see no insults at all. Now, look right next door. Medial to the fissure, we can see a neat little circular tunnel. So I have drawn it aside to make it more clear since the diagram is a bit crowded right now. So this is what we found in here. Yeah, so this is a neat little circular tunnel and this canal is called the optic canal. Now why is it called optic canal? Even though it's a different opening, you must draw it next to the fissure in your exam. Why? Because it carries two massive structures in here. As you can see, the thick optic nerve, that is the second cranial nerve, and you have the ophthalmic artery. So the optic canal comprises of the optic nerve and the ophthalmic artery which supplies the eye. Now take a look at your screen. This is your complete full exam mark schematic. So practice drawing this twice on a blank sheet of paper and you will never mix up these structures again. Now moving on. We all know that anatomy papers basically love clinical correlation. So if you get a 10-mark question on this fissure, the second half of your paper will ask you to discuss about the superior orbital fissure syndrome, that is the SOF syndrome, which I am going to discuss in the next part of this video. Now imagine a patient comes into the emergency room after a very severe maxillofacial injury, like a car accident, where the sphenoid bone in the skull gets fractured. Now you know that the superior orbital fissure is completely formed by the sphenoid bone. That is, the superior aspect is formed by the lesser wing of sphenoid bone. The inferior aspect is formed by the greater wing of sphenoid bone. And the medial aspect of the superior orbital fissure is formed by the body of the sphenoid. Now you can basically imagine the superior orbital fissure as a physical gap or a doorway between the lesser wing of sphenoid and the greater wing of sphenoid. Now clear? Now next we are going to deal with the superior orbital fissure syndrome. So let's connect the anatomy directly to the clinical presentation. Now we can call it a nerve to symptom blueprint. What do we call it? A nerve to symptom blueprint. So first we are going to deal with the clinical features in here. Total ophthalmoplegia. Total ophthalmoplegia is caused because we compress the cranial nerves 3, 4 and 6. All the extraocular muscles are paralyzed in here and the patient cannot move their eyeball up, down, left or right. It is completely fixed. This state is called as the total ophthalmoplegia. Now coming to the second clinical feature, we are dealing with ptosis. Because the superior division of the cranial nerve 3 is damaged, The muscle that lifts the eyelid, that is the levator palpebrae superioris, fails to work. So in this case, the patient's upper eyelid will droop down heavily, causing ptosis. Now the next clinical feature is the fixed dilated pupil. The fixed dilated pupil is caused due to the parasympathetic fibers traveling with the cranial nerve 3 getting crushed. So the eye loses its ability to constrict the pupil or accommodate to light, leaving the pupil wide open, causing it to form a fixed dilated pupil. The next clinical feature in here is the forehead anesthesia. So we all know that the lacrimal and frontal nerves we drew in the top in here, LFT. So these two nerves are responsible for forehead anesthesia because those branches of lacrimal and the frontal nerves are compressed. The patient will experience total numbness across their forehead and the upper eyelid, causing anesthesia. Next is the loss of corneal reflex. The sensory arm of the corneal reflex relies on the nasociliary nerve. So with that nerve out of commission, blinking when the cornea is touched vanishes. So there will be a loss of corneal reflex. So the SOFS syndrome, that is a superior orbital fissure syndrome, has 5 main clinical features that you will have to discuss in your paper. You will also have to write the reason why this specific clinical feature is happening in there. Now, the gold standard sentence that you must underline in your exam paper is, in pure superior orbital fissure syndrome, patient's vision is completely normal. Why? If you look back at our diagram, just look back at your diagram, you can see that the optic canal, it is sitting safely next door inside our protective bond tunnel in here. So if a clinician tells you that a patient has all these symptoms plus they have lost their vision, then it is not simply superior orbital fissure syndrome. It is then called as the orbital apex syndrome. This is a different condition because the injury has further spread back to the apex of the orbit, which is affecting the optic canal too. Clear? And there you have it, the superior orbital fissure and its entire syndrome decoded, mapped and ready for your university paper in under 15 minutes. So if this video turned a confusing textbook chapter into a clear mental roadmap for you, just hit that subscribe button right now to activate your learning loop. Drop a comment below telling me which first year subject or topic is giving you nightmares, and we will rescue it in the next video. Until the next time, keep studying smart. This is the Dental Catalyst.